My name's Beck Johnson. I'm the CEO at the Type 1 Diabetes Family Centre in Western Australia. I've had Type 1 for 18 years, been low carb for 17 and a half. My questions are for Dr. Kushner. The first one is, you talked about euglycemic DKA, and I wanted to understand what would be the ketone threshold you'd be concerned about in relation to euglycemic DKA?
I'm thinking about numbers over the typical range associated with interruption of insulin infusion or some other. So there's no absolute number, but let's say, for instance, you wake up and your catheter has fallen out and your beta-hydroxybutyrate normally runs at 1.5 millimolar and it's now 3 or 4 or 5. Well, that's a tip-off that there's something wrong.
So it's a relative thing to what you normally run. Second super quick question is hypo-unawareness. If the hypoglycemia isn't impacting a person because of the protective factors of ketones, they're not cognitively impacted, is hypo-unawareness an issue?
This is a really important question. So I had to rush through it in my presentation, but if you are unaware of your lows and your brain function is working well because you have those ketones in your brain as fat burning, isn't that a good thing? I suppose perhaps you could say yes. But we have to also recognize the possibility that you could deplete energy in your brain, and the delta between whatever your ambient blood glucose is at that point, let's just say for the sake of argument, 25 milligrams per deciliter, and death could be relatively small. So I don't really know. I don't want to do the experiment in man. Someone will ultimately do the experiment in rodents or some other model organism. It needs to be done. And I guess what I'd like to know is, are they always completely impervious to hypoglycemia, or alternatively, is there still some threshold we have to worry about?
Thank you.
Thank you. So the next question on my right, please.
Hi, this is for Dr. Mason, so you can put your hat on. My name is Tom from Durango. I should just, in fair disclosure, say I'm an asphalt contractor, therefore I am a little slow. Dr. Unwin, being British, calls me a tarmac guy. So, I have cholesterolemia, and I stopped taking statins, so I was interested when you got to Lp(a), which turns out to be highly prevalent in cholesterolemia. It's a concern because it's what I call a superthrombin. It's not only highly active in clot forming, but it forms highly resistant clots. You say, and I really hope this is true, that LPA is glycation dependent. So getting to the question, if you state that oxidative B100 loosens the endothelial junctions, I'm guessing that that's your hypothesis as opposed to an observed phenomenon. And I say that because if oxidative B100 damages the endothelium, then we're back to the problem that exists with the rest of the cholesterol hypothesis. And that is that atherosclerosis does not form in veins, and to the degree that it forms, obviously, in arteries, there is not uniform deposition, even though LDL in whatever form is in equal amounts in all of those environments.
Right.
Could you just elaborate your question there, sorry?
Well, so is the loosening of the junction observed, or is that a hypothesis?
No, that's definitely a fact. So tight junctions hold the endothelial cells together. You've got your endothelium there, individual cells, single layer. These proteins hold them together. There's, I believe, sufficient experimental evidence that once you start exposing the endothelium to oxidized LDL, and any insult to the glycocalyx lying on top of that has definitely been associated with loosening and impairment of the tight junctions, and that increases the permeability of the endothelium. And there's very good evidence that exposure to oxidized LDL of the endothelium will increase the passage by about 20 times.
But the endothelium exists in veins as well, and yet you do not see deposition of plaque. How do you explain that?
I'm not sure. The studies I've looked at have been based in arteries. There is certainly theories that the presence of the glycocalyx is, I didn't touch on it today, but it responds greatly to shear forces. and the shear forces certainly contribute to damage. The glycocalyx, it's almost like fronds of seaweed where they actually wave around in the currents. And when they wave around, when they're exposed to shear forces, remember they're exposed but they're protecting the endothelium, they actually release something called nitric oxide. And so because of the lower pressures within veins, they're not subject to the same kind of mechanical forces that we see in arteries. But having said that, I haven't actually seen any studies of oxidized LDL on veins.
I think Bret has a quick point on that.
I was going to point out the pressure differential, which is a huge variation between arteries and veins. And remember, vascular injury is part of it, not that pressure is everything. Some studies about shear stress have been a little conflicting, but vascular injury is a major part of that. So it's not just the cholesterol itself. There's also a nidus for that cholesterol to react to is part of the problem. So I think that could also possibly explain the difference between veins and arteries. So you sort of have to look at the whole pathogenesis of atherosclerosis and not just the lipoprotein particles in a vacuum by themselves.
Thank you.
I'd also like to make a very small point, and that is that you think of Lp(a) as all bad, but it might actually be a good player because it may be there to repair the injury, to cause a sealing. And if you follow Shaban's work, you would see that Lp(a) is actually soaking up some oxidative injury and causing a healing response. So I would encourage you to sit down and talk to her.
Moving on. You've been very patient. Off you go.
Hi, my name is Shel Girding. I'm from Boulder, Colorado. I'm a data scientist, and my question is kind of in general. I'm wondering how hydration affects, ketosis affects hydration. Being from the desert here, we probably think about it a little bit more than some of you people do. But I have noticed that when I go into ketosis, I tend to be more dehydrated. Does that make sense?
Okay.
Or?
Oh, we have a volunteer. Yes.
So I think what you need to understand is that fluid follows salt into the body. So essentially, when we're talking about hydration status, we're really talking about salt balance. And there's 4 transporters within the kidneys that are acted on by insulin. And that includes one that every medical student's taught about called the ENaC channel, stimulated by aldosterone, which is the main hormone that helps with salt retention. So in effect, when you go onto a ketogenic diet, you lower your insulin level, you're lowering the stimulus of the body to retain sodium, and therefore the body doesn't have that same stimulus to hold on to water. And if you read the renal journals, they describe hypertension as an insulin-dependent state, which means if you don't have excessive hypertension, excessive levels of insulin, you are not going to have what's termed essential hypertension. And that's why when you go on a ketogenic diet, what we used to term the Atkins flu, it's all sodium depletion. So you have a contraction of your intravascular volume. You feel dizzy when you stand up. A lot of people might have dry eyes. And funnily enough, people often get very thirsty, so they drink a lot, but then they just end up passing through their body and urinating a lot. And that's because they don't have sufficient sodium within their circulation to actually retain that extra fluid they're drinking.
A very good answer. Well done. Yes. Oh, hello. Yes,
hi.
Yes, please.
Yes, hi. My name's Jane Barnes. I'm an anecdote, but lifelong type 1 diabetic. It's been 50 years for me. And my question is about statins. I'm not on.
Who do you want to answer your question?
I don't know.
Oh, well,
Dr. Kushner, Dr. Ali, all we hear is anti-statin messages, and I get that. But for whom is a statin appropriate? Because I get told that from all sides all the time.
So
And I keep saying
I'm probably
no.
the most pro-statin person in the room, which is a very strange feeling for me, I have to admit. I'm very uncomfortable. It's not, anyway. So yeah, I would say there absolutely are times when statins are appropriate, absolutely. But the key is, like I said with the guidelines, the point is individualizing it for each person, because everything we do is a risk-benefit ratio. And if the side effects of statins were you felt better, you had more energy, you slept better, and your diabetes went away, then then there wouldn't be as much of a discussion. But because there are side effects, you have to weigh the risks and the benefits. So if everybody in your family dies from heart disease at a young age, and your numbers look terrible, and you have inflammation, and you're trying lifestyle and it's not working, then maybe a statin is appropriate in that situation, but it's finding the right target, right? So we get into this, I say we, the medical community, when you have a hammer, everything looks like a nail, and the statin's the hammer, and every lipid profile is the nail. But it's having more tools in your repertoire and using the statin as a tool when it's appropriate.
I think Nadir wants to add.
So I'll add my perspective from a statin skeptic. It's strange to find a cardiologist who's a statin skeptic, and I'll be shot by some other people. But I would believe the data if the data was conducted independently. All these statin trials have a heavy pharmaceutical influence. Before 2006, a statin manufacturer could do 10 trials and report only the positive ones. There are about 400 centers, 25 different countries. All the data is gathered by the statin manufacturers. The people who analyze the data are hired by the pharmaceutical companies. And it is so easy to ignore some patients because they just don't fit the profile. So I find it very hard to believe that blocking HMG-CoA reductase, which is such a key enzyme, and saying that you're getting all these benefits, when the studies, 19 out of the 20 studies, are not done without bias. So, I find it very hard to not show my bias to my patients.
Thank you very much.
Thank you.
Hi.
Please.
I had a question for Dr. Bikman on fat oxidation rates.
Okay.
And I'm Leonard. I read a lot of PubMed for fun, I guess. Anyways, I've only seen one study, the Alpert study, that has an estimate for fat oxidation rates during hypophagia, but it wasn't for ketogenic or fat-adapted subjects. And I was curious, in your research, especially with biopsies and all the stuff you're doing, were you able to calculate in vivo rates of fat mobilization and oxidation at rest in ketogenic or fasted state subjects?
No.
Okay.
No, but that's it would be kind of clever to do, and I'm not suited to do that. I'm more of just a basic wet lab. But what would be done is that it would involve a radio-labeled lipid infusion, and then you just track the degree to which the radio-labeled CO2 is being exhaled. That actually could be done quite easily.
Okay.
But
Can you do that at home?
because ketogenic, because low carb is still something that's so new, in a more kind of generally studied way, it's not surprising that it hasn't been asked, despite the fact that at its core it's somewhat simple to determine. But I'm extremely confident in speculating that oxidation would be up, simply because if insulin is low, you have disinhibited the beta oxidation. There could almost be no alternative.
Okay, thanks.
Yeah. Yeah, it's disappointing answer, but.
We're not disappointed. Not at all. Thank you. Right, next one, please.
Okay, this is a question for Bret concerning calcium scanning. My name is Dr. Mark Nelson. I'm a family physician from Chicago. Been teaching low carb for about 8 years now. And I got very interested in calcium scanning. So over the past 18 months, I've scanned about 300 patients. And I've kind of run into a little conundrum here. The range is 0 to 400, but a lot of my patients don't seem to stay in that range. I've got patients who are 1,000, 1,500. My record is 4,500. Now, my conundrum is if I say, go on a low-carb diet and I'll see you in 6 months, and they keel over from a heart attack next week, I put myself at a little bit of risk. So my plan with this is I've been sending them to my cardiologist. Well, actually, I've been doing a stress test first, and then if that's positive, you know what that leads to. And it has led to a few procedures, but I don't feel comfortable with that because asymptomatic coronary disease shouldn't be stented, right? And that's what this is. So what do I do?
What do you do? Wow, that's a great question. So yeah, so the question of sort of dramatically high calcium scores and how do you react to that? And the answer is really multifactorial, because I agree with the stress test for most people in that setting, because there have been studies showing that about 30% of people with calcium scores above 400 are going to have abnormal stress tests. The problem becomes the reaction to the stress test, right? Because if you say it's an imaging stress test and it looks like single vessel disease at a fairly high workload, that doesn't have to equal a cardiac catheterization and a stent. But I think it's good to know and to document because you want to know where they're starting and you want to measure for progression. Well, how do you measure progression with a calcium score that high? It's going to be difficult with serial calcium scores, but you could do serial stress tests and look for that to worsen. So that's one measure you can use to look for progression. And I think that's a big question we need to ask ourselves is how do we follow people over time rather than just reacting to one score? The other thing about calcium scores is they're not time stamped. So you don't know when that calcium came up or was deposited. So if someone's already on a low-carb diet and has been for a few months and has an abnormal calcium score, chances are it was the 30 years of the standard American diet that deposited the calcium and not the few months of a low-carb diet. But from a legal standpoint, you bring up a very good point. And I don't know what to advise, to be honest, from a legal standpoint, because even if it has nothing to do with it, the perception of it could be an issue for a family member or for a judge or something, and that makes me uncomfortable as well. But it comes down to you have to do what you think is right for the patient. I mean, it's clear whatever they were doing up to that point has had some contribution to that calcium score, to that vascular injury, to the development of atherosclerosis, and something has to change to make sure that doesn't continue.
Thank you. Thank you. Yes, please.
Hi, my name's Cindy Miller, registered nurse, times 41 years, down 75 pounds, family down over 900. But yay, for 3 years now. But my question, I specialize in wound care, and so I see everything from burns to traumatic injuries, but what my focus is, and I don't know if Dr. Bikman it's for you or Dr. Kushner it's for you, with the diabetic foot ulcer, when we see these, we know that they typically don't heal well, and some of that's biomechanical, and some of that is due to their chronic inflammation. So if you sample that fluid from a wound that's not healing on a diabetic foot, it's full of macrophages and proteases and reactive oxygen species and bacterial proteases. So we treat it typically with offloading. We treat it with antibiotics if appropriate. We put collagens and things in there to try to absorb the proteases. Do you know of anything that's being done with the presence of ketones? We know what it does to the rest of the body with inflammation. Would it impact, or is there anything studied on that? And if not, next question, number 2, would there be a benefit since flow to the toe is typically impacted severely? Could there be ever exogenous ketones? I know Dr. Dom's doing stuff with the DOD, but that was it. Do we know anything at all about wound healing, especially with wound chronicity?
Well, I'll give an answer, and then maybe Jake. There are times when inflammation is serving a very important job, and when it comes to such an explicit instance of wound healing, I would worry that if you're trying to inhibit inflammation, you're inhibiting healing or any attempts of the body to try to keep an infection at bay. So in the case of trying to apply the anti-inflammatory effects of ketones to mitigate the damage of the wound, I would worry that it would maybe make the whole body worse by compromising the body's ability to defend itself from what is obviously a sick spot.
And I agree with you if it was that part of the normal inflammation, but these get stuck into a very extended inflammation, and when you sample, proteases and other things should come up and go down during that 5 to 7 days.
No, I hear you. Yeah, I see what you're saying, but I would still say the inflammation isn't causing the problem. It's a consequence of the vascular damage, which itself could be a consequence of the hyperglycemia or any underlying vessel pathology. And there are people here more qualified to talk about that than me. But I would say by pointing the finger at the inflammation, we might be pointing the finger at the wrong thing. That inflammation, I would say, is a symptom of something else that's going on. But I would love to hear from someone else if there's other insight. I'm not a pathologist.
I would just say that as far as diabetes complications go, there has been, there are countless anecdotes of people who were on standard American diets, who had chronic hyperglycemia, who then went on low carb or nutritional ketosis, who achieved euglycemia and saw their risk for diabetic wound injury go way, way down. So there are people who've had, again, diabetic wounds, and then that risk seems to go away with prolonged years or decades of nutritional ketosis. And it might also be true of diabetic neuropathy. That's very exciting. So it's not really the answer you're asking, but giving patients hope that they could prevent amputations would be really important.
So I presume you're talking about matrix metalloproteinases?
Yes.
So they're actually constitutively secreted by the liver. And basically the liver is the only organ that has natural regeneration capacity. And because of that natural capacity, it needs to have this little amount of matrix metalloproteinase secretion to allow the turnover. It's what we call coupling. Any kind of connective tissue, it's a balance of catabolism where you break it down and anabolism where you build it up. Now, in a state of fatty liver, which a lot of diabetics will have, this constitutive secretion of matrix metalloproteinases increases to an extent that they're no longer largely confined to the portal circulation, but they now become systemic. And then, so all the features of healing that you want, so we're going to just ignore the rest of the inflammatory milieu for the moment, but these matrix metalloproteinases, which are the only proteases or enzymes with capacity to break down collagen in skin and things like that, they all come from the liver. And we know that when you fix you improve or you reduce the level of the MMPs. I mean, there's a hell of a lot of other stuff we could talk about in terms of infections and feeding on sugar and all of that. But in terms of if you're particularly worried about proteases, fix the fatty liver.
Awesome. Thank you so
Right.
much.
We've just, thank you. Thank you. We're going to have two more questions, but one of them needs to be a question for Zoe because she hasn't had a question. She probably doesn't mind. She's sitting here, so has anybody got a question for Zoe? Because they can ask the next question. Put your hand up.
It's going to be about poop, Zoe.
Yes, yes. We have a gentleman here with a question for Zoe.
It might not be about poop. I do things other than poop. In fact, I've never done poop before. I took myself out of my comfort zone today for that one.
So just so and please correct me, but the whole fiber thing, it's got my head spinning because to me, everything that I've been taught and in my education, I'm a family physician. My name's Marcus Haig. I'm from Albuquerque, New Mexico. So would you imply that people could just live in that box C and then not eat any kind of fiber, or is the vegetable fiber intrinsically different? Because I've kind of adopted a low inflammatory diet after my wife got ill, and I noticed my gut got better, but I am eating a lot of vegetable fiber, not so much the starches. Or am I misunderstanding? I mean, can humans just live in box A where it's just like cheese and meat and they just eat the whole animal and they get their fibers from like, I don't know, pig feed or do you still need part of that box A, or is it like humans can, I don't know, maybe the Eskimos or the Mongols, is this whole fiber thing, I can't wrap my head around it. So you've kind of blown my mind here.
Okay, we know if you go back to the basics of nutrition that we don't have essential carbohydrates, so we know we can live without carbohydrates. And indeed we did for about 10,000 years, or about 30,000 years, about 10,000 years ago, which was the Ice Age. And that was the time when we had the greatest development in the human mind and general condition. So the nutritional facts will say to us we don't need to move out of that box C. And we know a number of people. I joked that I only know two people, Sean and Michaela, but of course I know Georgia Reed, and you'll see more and more people on Twitter who are pretty much carnivores, so they perhaps don't even eat eggs and dairy. So meat and fish are zero carbohydrate, apart from maybe any glycogen that was in the animal at the point of kill. Eggs we see as virtually carbohydrate-free. Dairy, you start getting into a carbohydrate level, but you're still not into fiber. So that bottom box of zero carb, effectively zero fiber, or very low carb, zero fiber, we can live in that box. And I'm not saying that we should. And I guess one of the things that maybe I could say is just because fiber isn't essential, just because anything isn't essential doesn't mean it's not beneficial. So one of the best examples of that is laughter. Laughter is not essential, but it sure as hell is beneficial. It makes us feel good and all the rest of it. And maybe there is something with fiber. So when I went into the fiber arena, I did my PhD in dietary fat, so I go in with an open mind to say I'm expecting to find some evidence. Let's see what the evidence shows. And I was surprised because I thought there would be more evidence. But when there's one RCT and the rest is population studies, it's association, then you bring in the healthy person confounders and all the rest of it, and then you look at the fact that it ends up in the pan at the end of the day, it's really difficult to put together a case to say, we need this at any level. enjoy it. If you like vegetables, if you like whole grains, if you like fruits, and your metabolic state allows you to eat those kind of things, then enjoy them. But I don't think that they're necessary.
So just a quick follow-up on that same question. So you can get all your nutrients from box C?
Yes.
Essentially, you can live
Yeah.
there.
Yeah, you can. One of the really interesting things, there's some postcards on the Nutrition Coalition stand, or my husband will be able to reach one out of the bag. I have this great little postcard for my dietary fat presentation. And on one side, I've got saturated fat and total fat in different foods. On the other side, I've got the nutritional values from different foods. So it has a whole grain, a fruit, because we're told to have healthy whole grains 5 a day, and then it has really nutritious foods, which I've never found a more nutritious food than chicken liver, or any particular liver. Offal will win any nutrition competition. Oily fish is fabulous, and then either an egg or a dairy really helps with the bone nutrients, phosphorus, calcium, and so on. But you may be surprised to know, if you see that little postcard that I think somebody has passed to you, that liver has 4 times the vitamin C of an apple. We have to be able to get everything we need from meat, because we had all of those thousands of years when that was all that we can get. And if you speak to organizations who look at anthropological history and nutrition, they will say that when the hunter-gatherers killed the animal, they would pile in on things like the liver and the thymus, because they knew that's where they could get vitamin C and nutrients that are not generally in the organ meat. But we do also have people, Sean Baker, I think, is pretty much eating muscle meat and not much else. And maybe he'll drop dead in 10 years' time, 20 years' time, 30 years' time. We don't know. But we do know that there are populations that have survived on whale blubber and seals for a very long period of time. So it wouldn't worry me if I had to live on meat for the rest of my life. I wouldn't like it. I like carbohydrates quite a lot. But if I needed to, because I was like Michaela Peterson and my health was so much better, if I could only eat meat, then I would do it and not worry.
Thank you.
That brings us, I'm so sorry, it's the very last question, and it's the gentleman there. Go ahead.
Hi, my name is Bob Want. I'm in Dallas, Texas, and I manage a website called ketorecovery.org, and the purpose of that website is to, it's a 12-step program for food addicts, sugar addicts, and carbohydrate addicts that want to do the ketogenic diet. It's absolutely free, and we've got 4 meetings a week worldwide on Zoom. But my question has to do for Dr. Mason and Dr. Unwin and whoever else wants to answer it. When somebody starts, somebody's new, and they start a ketogenic diet, it could be either specifically like a sugar addict, or it could be just somebody that wants to get healthy. I mean, what would you suggest? How long a time would you suggest before they started fasting, intermittent fasting? Dr. Mason, do you have a response to that?
I don't see a problem with intermittent fasting as soon as you want. Basically, on a ketogenic diet, most people eat 1 to 2 meals a day. Because that's when you're hungry. So if we just rephrase it and just call eating when you're hungry, realistically that's intermittent fasting. And a lot of my patients, and very shortly after I see them the first time, they'll come back, and my first question to them is, how many meals a day are you eating? Because that will tell me whether they're actually responding to their hunger cues. And if they say that they're eating more than twice, my next question is why? And because usually they're habit eating, they're eating to the clock, they're eating out of fear that they might get hungry in advance of actually getting hungry. But in general, most people, if you educate them correctly about responding to hunger, they will do what is traditionally called intermittent fasting. They're going to skip a meal every day, maybe 2. And so you can do that straight away as far as I'm concerned.
Okay, let me ask Dr. Unwin, like, what if it's somebody that's got an eating disorder such as bulimia, and they get on the ketogenic diet? Do you suggest extended fasting, like more than a day or more? And when would you say that would work for them?
Sorry, you're asking about people with bulimia?
Yeah, bulimia or compulsive overeating. I mean, my experience is that food addicts can do fasting, extended and intermittent, successfully. But I'm just wondering what you would recommend. Should they do the ketogenic diet for a while and then do the extended fasting, or what? Extended fasting means a day or more.
Yeah. I've very little experience with bulimia. I've had 2 patients, and they did actually very well on a ketogenic diet because it turned out that it was the sugar was driving them. And when you took the sugar drive away, they did surprisingly well, but that's only 2 cases.
What about fasting, though?
Pardon?
Extended fasting, does anybody have any experience?
No, I have no experience.
Anybody on the panel have any experience?
I mean, I've had patients who have fasted for a week.
Okay.
It's not recommended. They usually come in and say, this is what I did, doc. And it's kind of cool because some of them have their CGMs and I can have a look at what their sugars were doing, and sure enough, some of them are going down to 1.5 or 2 millimolars, often at night, you know, sort of George Cahill territory. And they're always totally asymptomatic. I've never seen anybody with any issues from prolonged fasting. It's a bit hard to recommend medically, just from a medico-legal perspective. And certainly we know that the benefits with respect to autophagy and some of these other pathways will probably really begin to accumulate at about the 72-hour mark. So my gut feeling is that if you're doing a 2 or a 3-day fast, then that's probably long enough to get most of the benefits. I know there's other advocates that you need to, you know, do something like that every 6 months or so. But really that's all based on theory, and I don't think there's any solid science to support that at this stage.
Okay, thank you very much.
I was going to take an alternative view, actually. I have studied eating disorders. When I was at Cambridge, I was the women's officer, and we were getting literature on eating disorders. And I remember going to my female colleagues in the college and thinking, nobody's going to want this literature. And literally every one of my peers at the university was saying, yes, they had a problem relationship with food. And it's very, very common in high-achieving females. And of course, it's become far more common, not just in females, but across the board. My concern would be that bulimia is a very yin and yang disorder. It's a very extreme disorder. And there are 2 particular types of bulimia. One would be a overeating and then trying to undereat to compensate for that overeating. And then there's the more purging syndrome with bulimia. So somebody would overeat and then try to purge to get rid of that overeating, or perhaps to over-exercise to compensate for the overeating. So it's very much a yin and yang. And in my experience of working people with eating disorders, the more extreme you get them one way, the more extreme they're likely to go the other way. So it would worry me to encourage somebody with an eating disorder to fast for long periods of time, because that's actually what you do when you've overeaten for a long period of time. So you might have 3 or 4 days of overeating, and then you might want to punish yourself with 3 or 4 days of not eating anything because you've been so bad, because you've been so greedy. It is so psychological and emotional and mental, and it just concerns me that you're punishing the body in some way. My encouragement to overcome bulimia would be to have the person understand both the physical drivers of the bulimia, the particular foods, as David was saying, the sugar addiction, the refined starches, that the person will overeat for a number of different reasons, and hyperglycemia would be one of them. You're just swinging from a high to a low to the next need for sugar. So that would be one of the difficult things. But then also to work on the emotional side, to understand the role that food is playing in that person's life. And food becomes our prop from day one. We fall over, we cry, we get a sweet, cheers us up. We have a birthday, it cheers us up. Everything is celebrated with food. It's very deliberate. The fake food companies know that we need to have all of this going on, so we make this association that food cheers us up, and then we're 30 years old and our boss is mean to us and we think chocolate is somehow going to cheer us up. So we've got to work on both the physical side and the emotional side. And I really am not convinced that trying to starve yourself for 3 days is going to help that.
Let me ask this question, then I'll let you go.
Thank you.
Just to... sorry, can I just add to that?
Yes, please. It's the final comment.
I wasn't actually expressly recommending people with eating disorders would fast for 3 days, but I will make the observation probably about 40% of my middle-aged female patients, if you ask them sensitively enough, will admit to having had an eating disorder. And almost invariably, if you actually can take away their cravings and take away the constant hunger that they used to feel having a low-fat diet and the incessant urge to exercise to try and get that calories in, calories out balance working, you don't actually need to do much more. Their relationship with food normalises. It's important to recognise it and have the conversation with them at the start. But once you treat the physiology, a lot of the emotional distress, I mean, they still have a lot of anger at the diet that they've basically been pushed into in the past, but that doesn't seem to come across into any aberrant eating behaviours into the future.
Are you going to make those? Right, I'll bring it in there, yeah. So actually, that brings us to the end of all the questions. And could we just give a good round of applause, please?